Hello, my name is Janet McTaggart, and welcome to my Capstone presentation. The topic of my presentation is preventing ventilator-associated pneumonia, which I will refer to as VAP in this presentation. Now, I have here on this table over here at the end of the program, I have a post-test that I need for everyone to complete. And I also have a survey that needs to be completed after the program. And also I have handouts of the PowerPoint slides for everyone. Now, the objectives of this capstone project is to 1. Describe the statistics related to VAP, the signs and symptoms of VAP, the pathophysiology of VAP, and evidence-based practices for VAP. Now, I will talk next about the statistics about VAP. VAP is the second most common healthcare-associated infection in the U.S. It accounts for 25% of the infections in the ICU. The mortality rate is 46% compared to 32% in other mechanically ventilated patients who do not have pneumonia. VAP significantly increases the length of stay in the hospital. It increases patient healthcare costs. The average cost to treat VAP per patient for one occurrence ranges from about $40,000 to $57,000. Next, I will speak about the signs and symptoms of VAP. VAP is consistent with pulmonary infiltrate. There can be fever, there is leukocytosis, and then there is purulent secretions. Next, I will speak about the pathophysiology of VAP. It develops within 48 hours after the patient is put on mechanical ventilation. It is caused by microorganisms entering the lower respiratory tract, and it's caused from bacteria colonizing in the lung, causing the infection. Now, the databases used for this capstone project were CINAHL Complete and Medline Full Text. The keywords used in the search were ventilator-associated pneumonia and evidence-based practice. Next, I will speak about the clinical guidelines for VAP prevention. And VAP guidelines is pretty much called a VAP bundle. So the clinical practices for VAP is hand washing protocol, And hand washing is the main measure to prevent all infections. Also, for VAP prevention, mouth care protocol, elevating the head of the bed 30 to 45 degrees, minimizing the pooling of secretions above the endotracheal cuff, maintain the ventilator circuit, and evaluating that patient to see if they can be weaned from the ventilator. You want to also avoid intubation if possible, minimize sedation, perform spontaneous breathing trials in patients without contradictions, so the conclusions from the literature review is that the VAP bundle is effective in preventing ventilator-associated pneumonia. And also to follow the guidelines for prevention of ventilator-associated pneumonia. The references used for this Capstone project is from the Centers of Disease Control and Prevention, and an article entitled Ventilator-Associated Pneumonia, Discourse of Professionals About Prevention by Gutierrez, Pitera, and Nascimento. Other references are an article entitled Evidence-Based Practice in Nursing and Healthcare, A Guide to Best Practice, 3rd edition by Melnick and Fineout Overholt, and Using Evidence-Based Practice to Prevent Ventilator-Associated Pneumonia by Sedgwick, Reeder, and Nardi. So, in review for the post-test, signs and symptoms of ventilator-associated pneumonia are fever, purulent secretions, and the signs and symptoms are consistent with pulmonary infiltrate. Also, ventilator-associated pneumonia develops within 48 hours after the patient goes on mechanical ventilation. VAP is the second most common healthcare-associated infection. And VAP can increase the cost. The average cost of VAP is $40,000 per patient per incident. Also, to avoid VAP, the ventilator circuit should not be changed unless visibly dirty or malfunctioning. Once again, I thank everyone for participating in this presentation, And I ask that everyone please now complete your post-test and evaluation. Thank you.